Well, good morning, Docpreneur Nation. You're listening to Concierge Medicine Today's Docpreneur Leadership Podcast, and our special guest today is Dr. Julie Kolzet, and we're going to talk about making CBT work for insomnia. For those physicians listening, that's cognitive behavioral therapy. She is a licensed psychologist. And she's going to go into her background here in just a few moments, but she's definitely an insomnia expert, which I know my wife just last night had some difficulty dealing with, and we all have those, probably that you have those patients who are having sleep issues. And so we want to talk about that with Dr. Kolzet today, some best practices for related to CBT and what she's doing as a licensed psychologist. So Dr. Kolzet, welcome.
Thank you so much for having me. I'm very excited. I collaborate with concierge physicians on a regular basis, and I'm excited to talk to you about one of my subspecialties, which is CBT-I.
Awesome.
Yeah.
Well, before we begin, we always ask this of all of our guests and doctors is, how did you become working? How did you get to be where you are today working in healthcare? Was it part of the family business? Was it something that you're just really found a passion for? Or was it kind of one of those searches where you were on an Indiana Jones hunt in medical school or in school and you're like, I think that was not what I had planned out, but this is where I am and I really have a passion for it. So what's your story?
I love that question, and I love the movie Indiana Jones. Well, if it was A, B, C, D, I would choose D. So all of the above, family of doctors, medical practitioners, a passion for the field of health, mental health and physical health, and some trial and error too. So I remember attending, I think it was a cognitive behavioral therapy conference in New York. And I stumbled into a room of sleep experts, and they were all so welcoming. Anybody who is interested in joining the sleep community, the behavioral sleep community, you will find us to be a very warm, welcoming bunch. I won't say what bunches may be less welcoming, but the sleep community is somewhat small. It's growing every day, and there's a lot of support in the field. So I think my colleagues really embraced me years ago, and that also helped.
So how are you currently working? And we don't need to talk about specific individuals or practice names, but how are you currently working with doctors, for those doctors listening?
Well, I am based in Manhattan on the Upper East Side. At the moment, I am currently 100% virtual. And how I work with doctors is I attend conferences, I appreciate referrals and send treatment summaries to doctors. I also get referrals from patients, from hospital systems. It really runs the gamut.
And you're licensed in a couple of different states we were talking about off air.
Right. So New York, of course, Florida, and North Carolina.
So let's jump into the topic of making CBT work for insomnia and discuss some best practices with Dr. Kolzet. And you can reach out and learn more about Dr. Kolzet at DocTorKolzet. That's drkolzet.com. We'll put the links in the show notes, as well as her contact information, her email, etc., phone number. But here are some pretty, we're going to kind of lay a foundation and understand that our audience is primarily PCPs, family doctors, some physicians in some different specialties. So definitely we're not giving any medical or advice on this podcast. Please consult with your doctor. But we want to give some best practice, discuss some of these simple, practical things related to CBT. So talk to us a little bit about backing up. What is CBT-I?
Okay, so great question. CBT-I stands for Cognitive Behavioral Therapy for Insomnia. It's an evidence-based treatment approach, meaning that it's backed by data, backed by science. CBT-I is a combination of treatments that include behavioral therapy interventions, such as sleep restriction, stimulus control, which we can talk a little bit more about later, as well as cognitive interventions. So that's for the C part, which includes restructuring unhelpful beliefs surrounding sleeps and helping patients to decatastrophize negative thoughts about their sleep.
What does CBT-I or CBT, what does it affect?
What does it affect? So I think that it's important to, before I answer that question, is to talk about why it is important. Many patients come to their primary care provider for help with sleep. Insomnia is actually widely recognized to be the most common sleep problem, and it's actually the leading complaint in primary care settings. So how we know it works, and this is a roundabout way to answer your question, is patients are sleeping better. The patient is restored. They don't care about their sleep anymore. They're taking less time to fall asleep. They're having less middle of the night awakenings. They're hopefully sleeping to their desired wake time more so than before. They don't care. When I say they don't care anymore, they don't go around during their in their day to day thinking, am I going to sleep well tonight or am I not? And I should mention at the beginning, I'm a therapist, and towards the end, I'm a trainer. And if you ask a good sleeper how they fall asleep, they'll look at you and they'll say, what are you talking about? What do you mean? And that's when you know that the patient is really done well with CBT-I.
So you talk about in a recent article that you wrote about the Spielman 3P model. Discuss what that is for doctors who may not have read about that recently, or bring them up to speed.
Yeah, so that we could also refer that to the Spielman model as the insomnia model for sake of ease. And it's the go-to when explaining the etiology and treatment of chronic insomnia to patients. The 3P model posts that 3 sets of factors contribute to insomnia. There's predisposing factors, precipitating factors, and perpetuating factors. And when these factors go unaddressed for a while, the insomnia tends to take on a life of its own, and the patient ends up dreading the bed. So it is helpful to introduce the Spielman model early in treatment for both diagnostic and outcome purposes, as well as, it's important to tailor the explanation of the treatment plan so that it is most relevant to the individual. And if you'd like, I can go into some examples of those factors.
Yeah, go ahead.
Okay, so going to bed earlier, getting out of bed later, staying awake in bed are among some of the perpetuating factors. Now, that's the last of the P's that we went over. Those are things that patients do, really thinking that they're helping themselves, but what in fact they're doing is making the problem worse. So while behavioral interventions are often thought to have the most potency, which we can talk about some of the behavioral interventions, which, for example, would be getting out of bed when one can't sleep. I think it's important to mention that precipitating factors, which are responsible or partially responsible for how the insomnia began in the first place, need to be addressed. And that's why having a psychologist who is trained in CBT-I and general psychotherapy can I think, offer enhanced treatment to patients, because with patients who have experienced a loss of a job, illness, well, the pandemic, which of course we all experienced, and countless other stressors that come up in all our lives, sometimes those need to be addressed first before you tackle the patient's sleep. Sometimes you can do them tackle them both at the same time, but we can think of precipitating factors as kind of what tip the scale. Now, predisposing factors are things we don't really have much control over, like our genetics. Some people find that maybe their sleep was passed, their problems with sleep were passed down. Also problems with attention, anxiety, depression. We know there is a genetic component.
So if I'm a physician listening and I'm hearing from my patient on the other side of the exam room that they haven't been sleeping well, what tips or best practices or questions should be a physician maybe be asking these folks, or maybe even it's a colleague or a staff member that this physician is working with, that they're like, how do we I think the backing up question is, how do we differentiate insomnia versus the other factors that are out there? Like, is it something that has been in my life for a very long time, or is it something that, has really just come on in the last couple of weeks? Is it how do I know when I've got it?
So we want to think in terms of severity. We want to think of duration. We want to think of the presence of a subjective complaint. In order to have a diagnosis, one has to see their sleep as a problem. Oftentimes these patients, in terms of a clinical appearance, are tired yet wired. So they may, because over time have begun to associate their bed with anything other than sleep, it's very hard for them to even nap throughout the day. So a good starting question is, do you have a sleep problem? Do you have a sleep complaint? Now, I would say best practices: consider making a referral to a behavioral sleep specialist rather than simply handing patients a list of sleep hygiene instructions and or prescribing medication. Sleep hygiene instructions could include, and often does include, limiting caffeine, avoiding exercise too close to bed, eliminating alcohol, timing of medications. Now, I don't know about you, but the listeners, behavioral change is tough. So you really want to not just hand patients a list of generic instructions. You want to tailor the instructions almost like as if it was a prescription, and that takes time and I think experience. We know that it's very important to boost a patient's self-efficacy, their belief that they can make a change. So if we include a list of, or providers include a list of 20 instructions, and then the patient looks at the list and says, oh my gosh, maybe I can do one of these. Okay, but it can be overwhelming for patients to make change. And I think most listeners would agree that it's important for for patients to feel that they're in the right place with the right person and with the right provider. And I just want to add that if a provider, one of the providers who are listening isn't sure whether it makes sense to make a referral for CBT-I, refer anyway. The first session that I conduct with patients is an intake session, and it's very much like if a referral was made to a psychiatrist. So after the intake, I present to the patients, here are your options. Maybe one is CBT-I, maybe one is not doing anything, and letting the patient know that they're probably they're not in danger, but that the problem probably won't improve unless they do something. And maybe it would be a recommendation to work with other specialists to take a medication, whether it be a medication to help them sleep or a medication so that they can be medically stable and psychologically stable enough to begin treatment for their behavioral treatment for their insomnia.
Now, once that referral's been made, the intake has happened, what kind of communication should a licensed psychologist who is a sleep expert, what kind of communication should you as the physician treating the sleep issues have back with the referring physician? Because that's one in concierge medicine, obviously, that's something that if you're new to the space or not new to the space, you know that relationship and being involved in the patient's care is so vital and important to the referring physician. So talk to us a little bit about how that communication between the two professionals works.
Mm-hmm. Even though I said refer anyway if you're unsure, I often get calls from concierge doctors in particular who ask me whether it makes sense for a particular patient to be seen in my practice. And so it often begins with a phone call, and with the patient's permission, of course, it begins with a follow-up call after the first session where I go over some of my initial impressions. I tend to have a summary, usually one page, if the patient is comfortable with that, which goes over, what the treatment entails, what we're focused on currently, where we see the treatment going. I wanted to say before I forget that the International Directory of CBT-I providers that was put forth by the Perelman School of Medicine at the University of Pennsylvania, which I did some training at the fellowship level, they are the ones who update this directory of CBT-I providers. So if a clinician is listening and in the state of California where I'm not licensed, you go there if you're looking for somebody who has demonstrated expertise in this area.
And we'll go ahead and put a link to that as well as
Mm-hmm.
Dr. Kolzet's information. But again, tell us where you are licensed as well. I believe New York, of course, but what are those other states too?
Florida and North Carolina. I want to, if I could add, because that was a great question as to, and I think a really useful one for this audience, how I work with referring providers, concierge medicine doctors, that I am not a medical doctor. I do not prescribe medication. So while, let's say, the ideal patient, which we know most of our patients are not, is one that is not on any sleeping medications. I should say the preferable patient is not on any sleeping medications. That's not often what I see in my practice. I am often working with patients to help them titrate, taper sleeping medications. And since I'm not a MD, I work closely with the prescribing doctor, whether it's the concierge physician, the primary care, or a prescribing psychiatrist. And it's important to remember that even within the context of CBT-I, treatment goals vary. So some patients may come to me and report sleeping well. And then they share that they are using sleep medication. And not all are ready to discontinue their medication at sleep onset. So when starting CBT-I for insomnia, I begin talking with the patient about life stressors that led to their sleep challenges, as well as any other mental health concern, such as anxiety. And if a patient is not ready to taper off sleeping medications, it's often wise to explore when their insomnia first became problematic and to address any anxiety suspected of causing the sleeping problems. And it may start with a
let's differentiate between anxiety and depression related to CBT-I. Unpack that a little bit for us in those two categories.
Sure, they're close cousins, and the old way of thinking, back in 1983, the NIH considered insomnia as a symptom, I believe it was, of depression. It was not a disorder or condition in and of itself. So the treatment was to treat the primary disorder, depression, and insomnia symptoms sometimes were addressed and sometimes they weren't. And hypnotics primarily were used for the short-term treatment. That's what was recommended in 1983. But fortunately, the data has debunked this old way of thinking, and the NIH and the American College of Physicians is on board that insomnia now is a disorder, and it's typically comorbid with anxiety, depression, and it merits treatment in and of it merits treatment. So no longer just a symptom of depression. And matter of fact, by targeting sleep, we can influence the course of depression. CBT-I has shown to double response and remission rates to antidepressant therapy in depressed patients. And it's also been found to be a risk factor for hypertension, diabetes, and dementia. So the good news is that it represents one of the most modifiable risk factors you can imagine. Now, you asked about anxiety. A lot of patients have anxiety surrounding sleep. So, that's often where patients who have acute insomnia, meaning it hasn't lasted as long as chronic insomnia, the anxiety has begun to set in with that patient who is tired and wired. They begin to have anxiety surrounding the sleep experience, anxiety around bed. So an important differential is if they are lying awake worrying because they can't sleep. That's the profile of somebody who has really struggled for a while.
Well, let's unpack. And our guest today is she's a Ph.D., she's a licensed psychologist in New York, Florida, and you said North Carolina, is that correct?
Mm-hmm.
And is Dr. Julie Kolzet, and that's Kolzet. You can go to drkolzet.com. We'll put the links as well as all of our contact information in the show notes below. But we're kind of moving into the midway part, and then we'll move into our lightning round of questions. So a couple more longer questions that take just a couple more minutes to unpack. Let's talk about what everybody's familiar with and what patients really love to talk to their doctor about, but sometimes doctors really don't know. They're kind of good, bad, or maybe indifferent related to the clinical utility of the sleep trackers out there, but they can be pretty helpful too. So we want to get Dr. Kolzet's licensed psychologist. We want to get her thoughts on sleep trackers, good, bad, or indifferent. What's your thoughts on the clinical utility that you see of them, or maybe not see of them, and how physicians maybe should use or not use these sleep trackers and apps and all the fun technology that we love to play around with?
Well, if a patient is excited about something, you certainly don't want to poo-poo their enthusiasm, so to speak. Now, there are many different types of tracking devices out there. Some are clinical grade. Some are really focused on the consumer market. And that's what I think we're often talking about here. Sleep tracking devices could include actigraphy to help measure movement during sleep. And those are often used in research settings in hospitals. But we're often, what I see patients presenting with is maybe the Oura Ring or their Apple Watch data. And I would say I'm neither. So if that was A, B, C, D, I would select D. I don't think I don't think they're good. I don't think they're bad, and I'm not indifferent because patients, are bringing this in, and they do have kind of collectively, there are many different types, have some utility. From a CBT-I provider's standpoint, we don't know yet how to best incorporate these devices into our treatment. Very important to mention that the sleep diary that is obtained and used throughout treatment is how we collect data. It's a subjective tool. So patients will write down what time they went to sleep, how many awakenings they believe they encountered during the night. These are all estimations. We don't want patients to be looking at the clock. So it's a sleep diary, which is the way we track sleep. It's a crucial component, and it's designed to provide subjective information. And it's a key piece we work with sleep efficiency. I will say, which is the alignment of sleep opportunity with sleep ability. And in this way, the diary is a intervention and an assessment tool throughout treatment. A lot of these device companies do not publish their data, so we don't really know how well they work. They say they work great, but if you ask a researcher in the sleep space, they'll say, "Show me the data," and they
Oh, that's great.
don't.
Show us the evidence. That evidence speaks volumes. Our guest today is Dr. Julie Kolzet. She's a licensed psychologist in New York, Florida, North Carolina. We'll put her links in the show notes below. You can go to Dr. D-O-C-T-O-R, Kolzet, KOLZET.com. But her contact information and links is in the show notes below. So let's talk about and unpack stimulus control when we're talking about CBT-I. And this may kind of move into the next part of the question, and that's sleep interfering arousal and activation related to CBT-I. Those stimulus and the question also seems to kind of mirror one another. So unpack those topics for us.
Sure. So stimulus control is one component of CBT-I. Sleep restriction being another one. Or sleep compression. So stimulus control is designed to help patients limit the amount of time in the bedroom while awake. It can be perceived as a form of sleep compression or restriction. And the reason we want to limit the time the patient spends in the bedroom awake is because we want to strengthen the association between the bedroom, bedtime with rapid consolidated sleep. So when practicing stimulus control, we don't want to chase sleep into the bedroom.
So how does that makes a lot of sense, and I think there's a lot to unpack there. And of course, we're talking with licensed psychologists, so of course there's a lot more to unpack related to stimulus control. But I think that's really interesting because we watch these interior design shows, for example, and it's like, make the bathroom, make the master bedroom, and oasis, we hear all of these different things, but what we're talking about when we talk about stimulus control and CBT-I is there's the association of, if I'm in the room, then and I'm just poking around, I'm folding clothes, we watch TV, we got the kids in here, we're doing our homework in here. For somebody struggling with insomnia, that what you're unpacking there is pretty interesting. Do you have anything you'd like to add to that, or what normal patterns of patients you're seeing, and what maybe best practice or advice you have for doctors who are like, yeah, my wife has a severe back problem, so she needs to be pretty much horizontal to decompress that back. So we spend all of our time in the bedroom doing homework. It's a social setting, almost like the living room and the kitchen table.
Right. Well, I appreciate your comments, and you're right on point. Some people do need to spend and want to spend more time in bed because of health challenges. In the case you just mentioned of a woman with a back problem, we can get creative. And the good thing about working in a private practice setting as opposed to a research setting or managed care setting, just like working in a concierge medicine space, we can take the time to be creative. So with this patient, we could recommend that she perhaps position herself in bed a little bit differently during let's say the day versus the night. Now, during COVID, of course, and working in New York City with some younger patients from time to time, Manhattan apartments can be small. People can have roommates. During the pandemic, people were using their bed quite often for work. And that association between sleep and bed became muddled, or work and day became muddled. So maybe it means sitting on the floor on some pillows, creating that space for work, and the bed set up in the traditional sense for sleep. I think we want to think in terms of sleep as not just a bedtime thing, but a 24-hour thing. And during COVID, not only did the bedroom become associated with things other than sleep and sex, a lot of apartments or homes did. So one good thing about setting a set wake time and sleep time, which is a component of CBT-I, having a regular bedtime, regular wake time, is that it helps patients with behavioral activation. So if I know I'm going to bed, my bedtime is midnight, and my wake time, an alarm goes off at, let's say, 7, I have to factor in what am I going to be doing at 7, or it sets up the conditions where one can plan their day in a way that gets them out, that gives them some structure.
We haven't even talked about sleep apnea. I mean, there's plenty of people who are struggling with that, plenty of doctors who are working with patients who struggle with that. I don't know, maybe that's a whole other podcast or webinar for another day. But our guest today is licensed psychologist, Dr. Julie Kolzet. She's a Ph.D. with the licenses in New York, Florida, and North Carolina. We'll put her links in how to contact her related to CBT-I and sleep and all that she does. I think that this idea of stimulus control is so fascinating. So let's unpack a couple more questions in a longer form, and then we'll move into our lightning round of questions with Dr. Kolzet. Let's talk about sleep interfering arousal and activation related to CBT-I and its effect on insomnia.
Well, actually, what you just mentioned, sleep apnea, which is a common sleep challenge. I do work with patients who, I mean, part of my assessment in the beginning is to assess for sleep apnea. And for those listening on the call, the arousals that happen when there is when an apnea event takes place that causes people to wake up, right? If you can't breathe, your body has a fight or flight response, and you wake up. So somebody with untreated sleep apnea is having these awakenings at various intervals, depending, and at various times throughout the night, depending on the severity. And one could have sleep apnea and insomnia. And, in fact, one cause of frequency of urination in the middle of the night is sleep apnea. So let's say somebody has untreated sleep apnea and they're going to the bathroom in the middle of the night often, and then they have trouble getting back to sleep. Guess what? That's both. That's insomnia comorbid with sleep apnea. And the apnea can cause pressure in the chest, which can make one feel bloated, and also feel the need to maybe gas, or take in more air.
No, that's interesting. And so let's talk a little bit about the couples too, because do you ever see that you have to bring in the other significant other into the treatment program when you're talking about insomnia and CBT-I and lack of sleep? Because you hear about so many marriages, for example, where it's he snores so bad, and so he's sleeping in another bedroom, and then suddenly, 3 months, 2 months later, his sleep is terrible. Her sleep might be terrible, whatever. And it could be vice versa too. But, how often do you have to involve the other couple, and when does that make sense? Or, should this be a conversation related to that? I'm just throwing things at the wall because I think that these are some interesting conversations related to, we want to make sure that everybody in the family is not just the one person who's suffering, but there's obviously probably kids who are suffering from grumpy dad, or grumpy mom.
Right. It really can affect the quality of life of not just the individual struggling with insomnia, but it can impact family members, as you aptly pointed out. And for those who are really interested in couples CBT-I work, there's a whole body of literature out there. I personally I don't do much couples work. And that extends to my subspecialty of sleep. But the rules don't change, or the recommendations don't change. So if after speaking to a patient, I've tailored their sleep hygiene instructions in a way that makes sense for them, that they can feel good about, and they have a set bedtime and a set wake time, that holds true, hopefully, no matter what their spouse, if they have one, is doing. So sometimes what we'll see is if the partners want to be intimate, they'll do that. They'll be intimate in the bedroom, and then maybe one partner who's not in treatment will remain in the bedroom, and then the person who is in treatment gets out of the bedroom, and since they are involved in what we call sleep compression, which is also known as sleep restriction, which is aligning their ability to sleep with opportunity. And what's that looks like for patients is pushing their bedtime to be a little bit later, often, right? It's all based on what we see on the sleep diary. So if a patient was going to bed with their husband, who, let's say, falls asleep right at 10 o'clock and sleeps like a baby till 6 o'clock, good for him. But let's say the patient who's in treatment, the female, doesn't really fall asleep. She estimates till about midnight. So what we would do is we would compress the sleep to the time that she is actually sleeping. So that would mean her bedtime would be midnight. So we would think of creative, fun things that she could do that are maybe on a scale of 1 to 5, like a 5, that aren't too arousing. We don't want her to do jumping jacks or start doing work on her computer. We don't want her to be sitting on the couch reading a book, how to fall asleep, because that takes, that's, chasing sleep into the bedroom. We want maybe some watching TV. That's okay, because the light is not close to the face, the blue light, like in the case with the phone. So that's one way to do it. And this is these recommendations are in place for while the patient is in treatment. Now, patients may decide that they want to keep their sleep schedule as set during treatment, because by sleeping a little bit less on some nights or most nights, they're getting better consolidated sleep. So maybe that looks like not going to bed with your partner.
Our guest today is licensed psychologist Dr. Julie Kolzet, and we'll put the links and contact information for Dr. Kolzet in the show notes below. You can go to Dr. D-O-C-T-O-R, Kolzet, KOLZET.com if you're interested in learning more about what her practice does. She's licensed in New York, Florida, and North Carolina. So now we move into our lightning round of questions, Dr. Kolzet, and so you can be fairly brief on these questions because we're coming in for a landing here. But as we all know, these are not necessarily, there's no quick answers when it concerns, some of these topics. But for the physicians who are listening, these might be helpful, sound bites for you to maybe take in and consider. So let's talk about food and substances and CBT-I. What should be avoided? Maybe what should be considered?
Well, food. I like cupcakes. So napping is like a cupcake. Can you afford it? How's that?
I've never thought of napping as something that, naps are a struggle too. I'm a parent of 3 kids. And so it's one of those things you're like, if I take a nap, I'm going to be up all night. And so I like how you're approaching it. It is kind of one of those sweet treats. Can you afford it? Like, if there's a risk when you start to get older, you're like, it's risky. I don't want to take a nap, but I could sure use a nap, So what is maybe proper nap hygiene or proper napping etiquette related to if you do have some of these issues? Because next thing you know, you got insomnia, and you're working through all this and you're like, well, I took a nap. That was great sleep. Why can't I sleep? Or I don't want to take a nap because then I won't be able to sleep.
Right. And napping could be a talk in and of itself. Strategic napping is something that we can use, and for some patients, whether they have medical comorbidities, they may need to nap. Maybe they have some physical ailments that make them tired. But napping, if the purpose is to build sleep drive, we want the bedtime set. Let's go with the patient who we set her bedtime at midnight and her wake time, let's say at 6:30. If she takes a half-hour nap, guess what? Her bedtime is now 12:30. So we're taking away that half hour at the. So she's going to bed a half hour later. So when used strategically, napping is okay.
Well, let's dive back onto topic for a minute. Food and substances. I love chicken wings, especially late at night. Not every night, of course, but food and substances that should be considered or avoided. And I think we always talk about what should be eliminated. You shouldn't drink alcohol. You shouldn't eat these foods. What's maybe something to be considered? Maybe some things, obviously, that everybody knows maybe should be avoided if you're trying to get to sleep.
Well, having a regular bedtime and wake time is going to prime the pump and create the optimal homeostasis environment. while not as powerful as sunlight, food can be used to set your biological clock or your rhythms. So it is important to have regular meals, and if you can do it at regular times, great. We're going for routine and consistency. If something spicy or chicken wings, I don't know how spicy you like them. Of course, there's mild, medium, and hot oftentimes. If that's going to create some sort of indigestion that may keep you up, then best to avoid. Now, we want people to live happy lives, so I am for moderation. Of course, caffeine, and really digging deep, because some people don't know that, hey, Mountain Dew has caffeine in it. It's not a soda, it's not a brown soda, which often we think of as, Coke and Pepsi. It's the caffeine ones, but a lot of these soft drinks do have caffeine, and there's more and more being developed each day. So talk about caffeine with patients, limit it in terms of the time of day. If you're going to drink alcohol, drink earlier. Be honest with your provider. Encourage patients to be honest when it comes to alcohol and other substance use, because without honesty, we can't really help them. So you want to maintain a non-critical stance, and ask patients direct questions about these things. Of course, cigarette use is going to create all these mini arousals throughout the night. I had a patient in the past who was using, I think it was cocaine on the weekends, that messed up her sleep for the whole week, really disrupted the homeostasis. So we got to think about all these things.
Wow. Well, we're coming in for a landing here with she's Julie Kolzet. She's a licensed psychologist. She practices in New York, Florida, and North Carolina. She does a lot of work practicing in telehealth. So Dr. Kolzet, a couple more questions for you as we really wrap up here. Is you've given some great insights into CBT-I, sleep therapies, and some great things that physicians can consider. And I think maybe some questions that they may want to unpack further. I was talking with a concierge doctor not too long ago, and she was saying, you have no idea. I spend most of my time in the exam room talking about their marriage, I'm not a marriage therapist. And the topic of sleep comes up, and the topic of insomnia comes up. And so it is an important topic, and we're happy to be able to discuss it with licensed psychologist, Ph.D., Dr. Julie Kolzet. We'll put the links in the show notes as well on how to connect with her, and potentially even, if you're interested in learning more about how she can work with you or your practice. So final two questions for you.
Mm-hmm.
You've given a lot of best practices. I think that one of the things that maybe it seems so obvious, but sometimes doctors, if I heard this from my doctor, because I've talked about this stuff with my doctor. In fact, we've even had, probably in the last year, we probably talked about just sleep apps related probably about 20 minutes, in the some of the utility reasons he uses those and why he personally uses those. But I think that we don't talk enough about positions, or even, sleep aids, sleep masks. We're not talking about medications, but, your general things that you can do that are not things that you ingest or eat or drink, but more of like just body positions or sleep masks, or, talk to us a little bit about how you address those as a licensed psychologist with doctors and patients.
Mm-hmm. Well, going back to what we discussed before, we want to tailor our recommendations to the individual. One suggestion is that I often incorporate into treatment is to have patients create a wind down routine, maybe 2 hours before bed if they can. And what are they going to do during that wind down routine? Are they going to take a bath? We know that a hot shower or tub can help patients fall asleep. A cooler room is best because it's associated with staying asleep. And the shower or the hot shower, hot bath is important because it helps patients experience a drop in body temperature. In terms of positioning, what is comfortable for you? I think that's pretty individual. And making sure the bedroom is safe, comfortable, and free from light and noise. And if that means wearing a sleep mask, great.
I mean, maybe you've read the studies. I have not. It's probably something I should, but is there, you would think that we went through about half of our lives without sleep masks, and now it's like, okay, people seems to be pretty common. In fact, it was one of the things that one of our speakers at our annual conference asked for was, I would love a new sleep mask, And so is there any real value to those, or is it just something that's mentally, and psychologically are in our heads like, okay, it's dark, my eyelids are closed. Or I have dark light eyelids. So, is that really a thing? What's your thoughts on that? I know
Well,
it's kind of an unusual rabbit trail,
yeah,
but it's one of those things I think a lot of patients and doctors should be talking about because, next thing you know, you're like, okay, I slept half the night because the thing fell off. And so is there any value to these types of things?
well, you really do want to make sure the bedroom is comfortable and free from light, because light will increase the likelihood that you will wake up during the night. But just to wearing a sleep mask or no sleep mask, I think it's important not to put too much stock in any one of these sleep hygiene instructions, because it's really the gestalt that has the most value, and we don't want patients to become, for lack of a better word, let's say preoccupied with the amount of light that is in their room. If they find that sleeping with a mask is helpful, great. We just don't want to get into the lucky pajamas territory where patients have to sleep with an eye mask every night in a certain way for this amount of time in these pajamas, because guess what? That has the effect of chasing sleep. And we want patients to get to that point where they are like the person who is a golfer, right? A golfer doesn't focus on how they're swinging, they just swing.
Well, I think we found the title for this podcast, and I think chasing sleep is making CBT work for insomnia is going to be one of the things that we're going to title this, because people do tend to do this. And one of the things I'm grateful for, but yet I think we still need to just mention is we didn't poo-poo too much, or this wasn't a conversation related to iPhone or tablet usage before bed. And I mean, that I can see as a question that many physicians are going to start becoming more and more relevant and talk more about in the next 5 to 10 years, especially with maybe even as my kids get older. The doctor is going to ask them, how many beers or alcohol do you have, per week? And how close to your bedtime are you using your laptop, your tablet, your phone? Because that is something that I think that as a patient, I'm not a physician, but I am a patient. So I know what it's like to sit on the other side of you and these types of conversations. And when my doctor asked me that, I'm like, yeah, sure. One beer a month, of course that's not accurate, but I can see the same conversation related to tablet usage, blue light usage before bed, where it's, so how are you using your phone in bed? Is it right next to your bed? And these are sleep hygiene issues, but at the same time, I think that there's more patient education that needs to be done from a provider's perspective out there related to unpacking, hey, we got to talk about this blue light issue. It is your phone usage, the stimulus in neurology, all the neuroscience, we got to start talking about it more. And I'd love to see more medical conferences talk about that. And you guys, you're the sleep experts. So it's like, how do you tackle that really difficult thing? Because we're addicted to our phones. I got my phone right here in front of me. I'm not looking at it, but at the same time, it follows me everywhere I go because I got 3 kids, I got Life 360, I got all these different things. And patients are like, come on, it's not reasonable to be without my phone, like, but
Right. I think that,
where do you land with that?
well, look, phones are ubiquitous today, these days. And you mentioned, are they on their phones before sleep? How about, do they get up in the middle of the night and check their phone? Right.
Mhm.
So if they can keep the phones out of the bedroom, like we talked about with stimulus control, great, right? That's using the bed just for sleep and sex. Awesome. Now, sleep hygiene, which is what we're talking about here, is like hand washing. I had a mentor use this metaphor. Everyone should do it because it's good for you and it's good for those around you. But hand washing is not medicine, and it's not going to cure an infection. So I want doctors, the doctors who are listening, not to think that sleep hygiene is all the be all is all, be all end all, excuse me. A big component is restructuring patients' belief around sleep, helping them address those precipitating factors, what caused the sleep problem in the first place via talk therapy. I want to highlight and emphasize that I am a licensed psychologist, and I do have somewhat of a hybrid practice. So half my patients, I'd say, or so, come to me for sleep concerns. Other patients find me for help with adjusting to life in the new city, with other challenges related to work, family, career. So I do have a general practice. And tablet usage, there are some researchers out there who study not just whether light is good or bad, right? Generally, blue light is thought to interfere with sleep, right? That's why we don't want patients to be, on their tablets. The TV, as I mentioned earlier, is further away, so it has to do with proximity. But there's some researchers now that are looking at not just whether the light is good or bad, it's the content. What are kids, what are adults actually watching? How are they engaging? So it's more nuanced than just, are they on their phone or are they off their phone? Or if somebody's on their phone, let's say listening to a Calm, I'm not endorsing Calm podcast, just thinking of it as an example, a podcast, and they use listening to a podcast or a Calm meditation, that's different than maybe if they're engaged in a work email or a school project, which may be more stimulating than the others.
Our guest today has been licensed psychologist Dr. Julie Kolzet. You can go to Dr. Kolzet, KOLZET.com. We'll put the links as well as contact information for Dr. Kolzet in the show notes below. But our last question for you for the day is, if you were to, we ask this of all of our physician guests, is if you were to think about, one story or a story that really resonated with you, that you're like, you know what, this is why I do this. Like, I could die happy. I could hang up my spurs. I could hand over the keys to the practice to somebody else because this is why I do this. What's one story of probably many that might come to mind for you?
I like that question. So I had a patient tell me that some of the most helpful guidance that took place in our work together was related to cognitive reframing. So that's the C in CBT-I. And the patient gave me permission to paraphrase, and I did so in an article that you can find on my website relative to what we're talking about. And this article is was written by me with the clinician in mind. So if you like what we're talking about here, please read this article. And in this article, I paraphrase the patient who I'm mentioning here now. And he said, when I feel like I am getting a little anxious about my ability to stay asleep, I say to myself, let sleep come to me. If you chase sleep, you will never catch it. This is a behavioral situation.
Wow. I know that is pretty powerful. And I know for me, it has been something in the last 5 years as a busy parent busy working person, lots of responsibilities. It's like I go to another job as soon as I leave my current job. And sleep is definitely something that we all have to think about, especially physicians. You have an impossible workload, and you're helping so many people, and your workload's a lot harder and bigger and more challenging than others. And we want to thank every physician listening, especially our guest today, licensed psychologist, Dr. Julie Kolzet. She's a licensed psychologist with practicing in New York, Florida, and North Carolina. We'll put the links to Dr. Kolzet as well as the articles that she has written in her blogs as well, and her websites, all that kind of stuff. We want to thank you, Dr. Kolzet, for being our guest today. We can't wait to unpack more about sleep in the near future. So thank you for helping physicians understand maybe what they can unpack more inside of their practice with people who are suffering with sleep. And I think we can all agree it's probably everybody. And so thank you, Dr. Kolzet, for being our guest. You are truly an example of it's no longer about being the best doctor in the world anymore. It's about being the best doctor for the world, for your patients, and for your local community. And we're grateful that there's physicians and doctors and PhDs and psychologists out there just like you who are doing some great work in highly specific areas, especially related to sleep, because I know we could all use more. But thank you, Dr. Kolzet.
Thank you. And you don't have to suffer. So that's my parting message.
Thanks.
Help is available.